we will move on to request Aniruddha to log on and speak on bridging the unmet need in DME. Yes, Aniruddha, we can see your slides.
Good afternoon, everyone. So, first of all, thank you very much to Lalit Verma sir, to the entire leadership of AIOS and Novartis for organizing this session. Like sir mentioned, we will be diving deep into Brolucizumab and addressing the unmet need in diabetic macular edema. So, in general, these are the contents that I will be talking about in brief: the disease burden, the unmet need from the perspective of the patient, physicians, and the healthcare system, summarizing the clinical trials, and then I'll show you some real-world cases. So we know that diabetic macular edema is a significant problem all over the world, in the Middle East, also in India now, and the projections are that we have millions and millions, 74.2 million people already affected by diabetes, and this is going to only exponentially increase. And we have significant number of people already with diabetic retinopathy in this population, and this is to the tune of more than 15 to 20%. So, if you look at patients with
Aniruddha,
DME,
one sec, wait.
Yes.
Achha, they had seen. Okay. Yeah, carry on. We are not seeing. They are seeing. Carry on.
Thank you. So, if you look at the problem from the three perspectives, and I'll be talking to you briefly about all of them: patient's perspective, physician, and healthcare perspective. I'll tell you how challenging it is and why we need molecules such as Brolucizumab to address this problem. So of course, if you look at the patient's perspective, the patient have multiple comorbidities. They have to not only look at their retinopathy, neuropathy, nephropathy, and other diseases. And so this not only adds to their treatment burden, and so we look for an agent which is long lasting and is very effective anatomically. Patients with DME have poor quality of life due to various reasons, and this includes not only the eyes but in general the dependency and lack of social functioning that they can do. And of course, because they need multiple clinic visits, it takes away time off from work for the injections. Now, in general, in India and Europe as well as US, we see that the compliance for DME treatment is quite low. If you look at the Indian data, 50% patients are non-compliant with repeated injections. And I was hearing from the previous session talking about protocol S. And really, if you have to follow such protocols, it becomes extremely difficult in a country like India where you have to do multiple injections periodically without a specific deadline to this. So, of course, there are long waiting times, there are other medical conditions, and this leads to loss of productivity, and it affects compliance directly in patients with DME. And of course, this will ultimately have an impact on the visual acuity. Real world evidence also shows poor visual outcomes with less number of injections. So in agents such as aflibercept, ranibizumab, if you do not keep persisting with injections, they will have suboptimal outcomes. If you look at our perspective as a physician, we of course, all of us like to have agents which can be long lasting. So in the PAT surveys, the ASRS keeps sending these surveys almost every year, and we see that year after year, we all ask for agents which are long lasting and have longer duration of action. So this is again the same thing which shows that you would like to have agents that have greater improvement in visual acuity, reduction in macular thicknesses, and improvement in diabetic retinopathy severity. From the healthcare system, of course, the treatment burden, monitoring burden, the cost, and the utilization of OCT, and now you have OCT angiography, this has a significant impact on the healthcare system in terms of the hospital visit days, the outpatient days, the eye care related visit days, and the medication visits. So all of this just leads to limiting the capacity for treatment in the working age population. We have young patients now having diabetic retinopathy, especially in the Middle East. We have a lot of patients who are in their 30s presenting with very high HbA1cs and detecting with new onset diabetic retinopathy rather very early, already leading to a loss of work productivity. So these not only lead to clinical challenges but also administrative and cost challenges, especially in countries such as ours. Now, I'll just like to tell you about the multifactorial nature of DME and the key points and summaries from the clinical trials that have been addressed by Brolucizumab. We need agents that satisfy these unmet needs, provide maximum and sustained visual gains, and require fewer number of injections, benefiting all the patients, physicians, and the healthcare system. How does Brolucizumab address this gap? Now, the KITE and CRESTAL study were really the phase 3 landmark studies that led to the approval of Brolucizumab in diabetic macular edema, and I was fortunate to be a part of the KITE, which had the Indian arm. So you see, both the KITE and CRESTAL taken together have a very good international representation of patients, and these were compared with aflibercept that was used as per the label. Now, if you look at the CRESTAL, you have three arms that have been highlighted: the 3 mg Brolucizumab, 6 mg, and aflibercept 2 mg. And the primary objective was met for Brolucizumab 6 mg, and the mean change in the visual acuity was comparable to aflibercept with fewer number of injections with Brolucizumab 6 mg. So you have a significant number of patients there, and you see also the change in the visual acuity correlates with the macular thickness decrease, and you see robust improvement have been achieved with Brolucizumab in both the studies. And you see minus 159 or minus 180 micron difference at the average of week 52, and so this meets the secondary endpoint for these studies. So you see more number of patients with Brolucizumab achieved a very good anatomical outcome with a decrease in macular thickness less than 280 microns at week 52 despite lower number of injections. So you see you have almost 7 injections versus 9 and 11 versus 15 injections at week 52 and week 100 respectively, and this is also seen in the KITE study. So this is a big difference in week 52 and week 100, especially the first 2 years when the patient has an active disease. And fewer patients have persistent IRF and SRF at week 52 despite lower number of injections. So there is no doubt from clinical trials and from our real world experience that the anatomical drying effect of Brolucizumab is far superior than some of the other agents that are available to us. So you see observed treatment status at week 100 in both KITE and CRESTAL, you have about 60% patients on Q8 weekly treatments in the KITE and CRESTAL taken together. And if you look at patients who are on more than Q12 weekly, that amounts to about 47%. So this is close to saying that almost half of your patients can be maintained every 3 monthly injections, which is really something that we all look forward. And this translates to about 4 or 5 injections every year if the disease remains stable. This is a very much a desirable change from the other agents that we talk about monthly injections. So in both the studies, as you see the KITE and CRESTAL, the number of active injections in the year 1 are less than aflibercept arm, and this carries on in the year 2. And so if you look at the total number of injections, we are talking about a median of 11 injections of Brolucizumab versus 15 injections of aflibercept. You know what this means is that you are looking at an agent that can potentially increase the treatment interval without compromising the visual acuity or anatomical. In fact, it's giving a better anatomical outcomes, and this is something that we all desire. Sir mentioned about the safety profile, and the clinical trials in DME did not really bring out safety signals of Brolucizumab. And to my knowledge, I have injected several patients. We have used in Cleveland Clinic here, hundreds of patients have been injected with Brolucizumab. We don't have any in-house patient with intraocular inflammation in the context of diabetic macular edema. And therefore, this becomes really important for us. The safety profile has been consistent with no new safety signal. And I'm talking to you this specifically about diabetic macular edema. We are using it as a first line or first/second line treatment for DME because of its excellent safety profile, at least in our population. So in the real world, I'll show you some case examples. This is a patient who is treatment naive, diabetic macular edema. And when I look at the OCT, I just not only look at the OCT, but sometimes looking at the infrared also gives you a very good idea about the leakage around the macula. And you see here that not only in the center there is paracentral edema, and this patient definitely needs an injection, was treated with Brolucizumab. And you see the patient had a very good response sustained with Brolucizumab, and therefore this can be a very effective first line agent, as I said. Usually I start it and I try to give it initially monthly, 4 to 6 weeks initially, and then I use treat 10 or a mixed sort of a protocol where I call the patient every 6 weeks initially, and then from beginning from the third to fourth injection, I think I can extend the treatment intervals. This is another patient where you have hard exudates in the center, and this is what concerns us because a lot of times traditionally when you look at treatment with anti-VEGF, our fear is that these hard exudates can become subfoveal and they can cause visual acuity obscuration. This patient received aflibercept, and if you look at this hard exudates, they have kind of migrated, changed. There is cystic edema still, and this patient was continued on aflibercept, and now if you look at the hard exudates, this becomes very concerning. In the past, we used to depend on probably corticosteroids as a better alternative to anti-VEGF to absorb these hard exudates. So in this particular patient, we actually did not do corticosteroids. We did Brolucizumab, and you see the anatomical response. The hard exudates just disappear. And I think this is something which should be looked at in more details. And these kind of responses, especially resolution of hard exudates, fibrosis, they may be quite better with agents such as Brolucizumab. This is another patient of treatment naive DME. I'm talking about the left eye. You see the initial visit, the patient received one Brolucizumab. 6 weeks after the first dose, the patient definitely had to receive another injection. The OCT itself is a non-favorable OCT. So when I look at the OCT, I tell the patient this is a non-favorable OCT. You will need multiple injections. The second visit that you see the number of hard exudates have again decreased. After the second dose, 6 weeks later, the visual acuity has improved to 20/80, and the patient does receive the third injection. Now this is 7th week after the third dose. You see the anatomical response is much superior, but you have to persist, and this patient has received the fourth injection. 7 weeks later, again, you go ahead with the fifth injection. Now you see here I've already started to extend, and this is 13 weeks after the fifth dose. So this is typically what you will encounter in practice, that after 4 or 5 injections, you will realize that now you can extend. And you see the visual acuity is so much better. It's 20/50 now compared to 21/25. And of course, we persist. Some of these patients you may require for a long term, 12 weeks. This is 12 weeks after the 6th dose, and then 13 weeks after the 7th dose. So you see, this is how you can kind of extend the treatment interval, beginning 3rd to 4th, sometimes earlier, sometimes later, and you may extend it beyond 12 weeks or even more. This is another example of a patient with age-related macular degeneration here. You see there is leakage and there is neovascularization on both fluorescein and ICG. This patient was a long-standing case. They received multiple aflibercept injections in 2016 without any response. Continued on aflibercept in 2017, hardly any response. And you see the OCT is so bad. There is so much of fluid, the bridges are broken of the intraretinal tissue. And this is actually a picture after PDT. So, as in 2017 or 18, we did not have so many options. And so PDT was tried for this patient, but you look at the anatomical response is actually much worse. In 2021, ranibizumab was tried, aflibercept was tried, nothing worked. This patient was 2200. And so 2200, I think, is a visual acuity where you can still maybe persist with injections if the patient feels comfortable or some mild improvement. This patient received Brolucizumab, and you see this is the impact of the anatomical response. It's not the anatomical response alone. He improved from 2200 to 2125. And so this gives us, the confidence to continue the patient on Brolucizumab. So the key obstacles really in DME are to reduce treatment burden. We want to maintain a sustained response. And Brolucizumab does give you the option of sustained response with better anatomical outcomes, longer treatment-free intervals, and in DME it has a very well tolerated safety profile with no new safety signals. These are the statements of Agenx, and I thank you for your attention, and I'm happy to take any questions. Thank you.
Thank you, Aniruddha, for an excellent insight into usage of Brolucizumab. My question again will remain, how do you get rid of this fear? Because I am reasonably convinced that, you showed excellent slide, patient resistant to aflibercept, even PDT, and multiple injections, but miraculous response on Brolucizumab injection. You see, in last session also, we were shouting about the drying effect of Brolucizumab, but majority of the people still do not want to use it because of the fear. So I am unable to, convince people because they go by all the American data and kite crystal studies and the label which Novartis has inserted into that pack, and maybe some personal experiences also. So they say that, till the time it is resistant to one drug, two drugs, three drugs, then they may try. And then we have Mallika Goel with us. She is a fond user only of aflibercept, and hard exudates she aim is to, convince each other basically. Aim is to either you get convinced or, you convince us. Because the slide which you showed, last slide, was very, very convincing. And you said hard exudate may be one of the biomarker for you to use Brolucizumab. So Mallika says hard exudates, drug of choice still is aflibercept, no steroid also. So I'll have Mallika's reaction because she has already got up.
I think Dr. Agarwal's point is well taken. When you have hard exudates, you need a very effective agent. If you are not using steroid, then it should be a newer potent anti-VEGF. So since aflibercept was the drug available, and it is safe. I agree that Brolucizumab is very effective, and so that will be a very good option for
So have you
hard exudates.
tried Brolucizumab in such patients?
No, I have not tried, and because of the risk of inflammation, I do not want to take. If there is aflibercept which is working as well, or maybe little less in some cases, but it's better than taking a risk. I would prefer not to take a risk and then.
No, but the point I want to say is that, Aniruddha, you said that there is less inflammation in DME patients. How can you explain that vis-a-vis AMD?
So I'll just give a brief perspective on this. Inflammation in Brolucizumab is very different from AMD eyes and DME eyes. The clinical trial data on kite and crestal actually did not show safety signals in DME. I don't have a real working hypothesis, but probably there has been a Japanese study on risk factors for inflammation after Brolucizumab, and the risk factors really include high age, more than 80 years, or previous inflammation to other agents, and AMD eyes. So I think in AMD it's a different story altogether. In DME I'm not really worried about inflammation, and I tend to use Brolucizumab quite often, and so in my practice the fear factor which sir said is difficult to get rid of it completely, but because you build a confidence on experience. So once you start using the agent and you see the good response, I don't typically use any corticosteroid agents. I don't do any wide field fluorescein angiography before Brolucizumab. So in DME eyes, I'm actually very confident of using the agent. I may be calling the patient initially early for a follow-up to look for anterior chamber cells, but even that over a period of time I have stopped doing it. So I think it just takes, you have to take the initial leap of faith, and then once you develop a confidence in the molecule, it will be easier to proceed with that.
So DME, you see, there is a inflammatory theory also. Whenever we, talk of steroids, we always, there was a BJO editorial that is DME an inflammatory disease, and a lot of studies have been done which show various cytokines levels elevated and good response to steroid also. And here you make a very confident and very loud statement that you do not use steroids and instead prefer anti-VEGFs, and that too specifically Brolucizumab.
I think, sir, with the newer agents coming, the maximum hit has been taken by corticosteroid implants.
Yeah.
Because all of us fear cataracts, glaucoma, steroid responsiveness. And so if you have an agent which is giving you a response which lasts for 3 to 4 months, then why not to use that agent instead of an implant? So I think that is what has happened really. We are using Eylea, like ma'am said, as first line, but I think these newer agents have also taken up the place.
And I think,
100% I agree with you, because these newer agents, because of the durability, because of less number of injections, because of better drying and sustained similar vision or comparable vision, does make sense that this new agents may become the first line of management, and maybe even Ranibizumab may see its way out in next couple of years.
I think, Lalit, if I can add, I think that the concerns about inflammation have been vastly overstated. At least in Eastern India, I remember last time we had AIOS in Eastern India, Lalit was chairing some session, he said, you're using too much Brolucizumab. We've used a lot of Brolucizumab. Anybody from the Dishai group is here, they will put their hand up. The enormous number, I used as first line in DME. I have not personally, myself have treated more than 300-400 patients with Brolucizumab, not seen one case of IOI. I've seen 2 cases of IOI referred by somebody else, but when they come in from somebody else, you're always worrying, is it the drug or is it the technique or is some betadine gone into the eye or something else happened? You don't know.
I agree.
But in my hands, not one IOI in a margin. So real life, it may be genetic difference between Caucasians
we should not talk about, because these doctors have been injecting other agents. If you say that betadine gone inside the eye or other cause of inflammation, that should not. But I agree with one aspect. I agree with one aspect. I agree with one aspect, that in Indian eyes, inflammation is less. There's no doubt about
I've
it.
also seen 4 inflammations, serious inflammations after Eylea referred to me.
Aniruddha,
So that
true.
question is valid. I'm sorry, but
No,
we
no.
were just speaking earlier that everybody is injecting right, left, center.
How many in the audience? How many in the audience have used Brolucizumab? So I think 50% people have used Brolucizumab, but rest 50%, we have to convince use because of this wonderful molecule, not because this is a sponsored session, but primarily I still have data, so many patients, not one, where we bank upon a drying effect. Drying effect is actually too much, and I agree with Aniruddha's statement once that these newer agents with promise of increased duration may make a dent in the steroid market.
Aniruddha, one question. What do you think about which drug would be better for DME, Vabysmo versus Paganex?
Very difficult question to answer, sir. But what I do is I look at some biomarkers, let's say on the OCT. If it's a plain simple eye with a treatment naive, maybe macular edema without a unfavorable OCT, then maybe yes, faricimab could be a very good agent to start off with. But if I feel that the OCT, there is a lot of fluid, subretinal fluid, and there is a lot of capillary non-perfusion, in those eyes I generally like a stronger agent like Brolucizumab. So this is how I typically do it. All of us have a different way, but sometimes it is random. And I'm being honest, because I may not be able to have a strict criteria when I do Brolucizumab or faricimab or Eylea. It depends on so many factors taken together. But I encourage, I think in the audience there are many who don't use. I encourage you to at least try it in patients of DME. Try to use it, see how you feel. And sometimes we are trigger happy, we feel there is inflammation. So I had one patient referred to me with AMD, injected Brolucizumab, and it was referred to me as occlusive vasculitis. And it was nothing but a subretinal hemorrhage, which is common in AMD eyes. So some of us may fear the unknown, and therefore you may feel that there is an inflammation or a vasculitis, but it may be sometimes maybe a vitreous hemorrhage or subretinal hemorrhage.
So what you are advocating is a stronger agent for a severe DME.
Yes, I think so. I think that has come into our minds, especially looking at the data from Kite and Crestel. Unfavorable OCT, probably I lean towards Brolucizumab.
No, but Aniruddha, one more point which I loved about you is that, the older patients have more inflammation, so these diabetics are younger patients. So there's a less incidence of having anti-Brolucizumab antibodies in there because they are younger.
Yes.
And these older patients have a higher incidence of maybe getting those, anti-Brolucizumab antibodies. So that was really a great point which you brought out, that the younger patients who are diabetics will have a lesser incidence, which is reflected in the studies. Am I right?
In U-retina last year,
Yeah.
sir, if you look at the data, there was a poster presentation on faricimab related IOIs. And again, so IOIs can happen from any agents, from aflibercept, from ranibizumab, all of these are biologics. And these are all high risk in high elderly population more than 80.
Aniruddha, one question which is striking me is what about peri-cataract surgery period? Like a patient, suppose is having cataract, reasonably advanced cataract, plus has DME, and he has been maintained on some anti-VEGF agents. So, what is your approach? Because you say you use Brolucizumab as first line in diabetic. So,
Yes.
how do you approach?
For cataract surgery, even if the patient is maintained on anti-VEGF, I generally shift to steroid. I do steroid implant either at the time of cataract or 1 week prior. And once the cataract event is over, then maybe I can go back to anti-VEGF. But in those cases, I depend on steroids.